Welcome everybody to our presentation today, Advances in Blood Biomarkers. Anti-Amyloid Antibody Therapies for Early Stage Dementia. And I'm delighted to be here with you. I'm Gary Small, Chair of Psychiatry at Hackensack University Medical Center and Behavioral Health Physician-in-Chief for Hackensack Meridian Health in New Jersey. And with me today is Dr. Paul Schulz. He's the Rick McCord Professor in Neurology and Humphrey Family Professor of Neurodegenerative Disorders, as well as the Director of Memory Disorders and Dementia Clinic and Neuropsychiatry and Behavioral Neurology Fellowship at the McGovern Medical School of UT Health, Houston, Texas. This event is supported by an independent educational grant from Eisai. So before we get into the content, just a few housekeeping items, some information on physicians ACCME credit, also credit for nurse practitioners, physician assistants and associates, as well as nurses credit for ANCC. Thank you to MedNet and Amitco for organizing this event. So to get your CME or CE certificates, once you've completed the seminar, you'll be able to participate in a brief evaluation. You'll download the certificate, but you have to complete them by February 3rd, 2025. That gives you plenty of time. And disclosure of conflicts of interest here, according to the ACCME standards. You're probably familiar with all this. And disclosure of unlabeled use, as well as this disclaimer. So here's learning objectives. Summarize the pathophysiology and the clinical presentation of Alzheimer's disease. And you see the abbreviation for that, AD. Assess the blood-based biomarkers in diagnosing early stage Alzheimer's and its use in prevention. And finally, identify strategies to optimize disease-modifying anti-amyloid antibody therapies in managing patients with early stage disease. Here's the agenda. Spend about 40 minutes. I'll present a clinical vignette, discuss the biomarkers, and then we'll have a post-test ARS clinical event. Dr. Schulz will have a second clinical vignette. He'll talk about the clinical trial data on safety and efficacy, and we'll have a post-test clinical vignette, and then we'll try to entertain your questions and have a panel discussion. Well, let's start with the pretest case number 1. This is a 65-year-old retired educator who's looking for a second opinion for memory complaints. He's forgetting names and faces and misplaces his glasses. The previous doctor he saw ordered an amyloid PET scan, and he was told that he had Alzheimer's disease. He got very anxious about his future, and his worries distracted him from his usual exercise routine and healthy diet. On examination, he scored 29 out of 30 on the MoCA test and showed evidence of anxiety. His medications included Lipitor and Cialis. Physical and neurological exams were within normal limits. So here are your options. Would you recommend ordering, and you can use a computer that will fill it in, ordering a battery of both CSF and plasma biomarkers to confirm the diagnosis, repeat his amyloid PET scan, educate him. Letter C would be educate him about the prognostic implications of amyloid PET positivity and encouraging him to return to his healthy lifestyle. D, beginning anti-amyloid therapy, or E, ordering the tau PET scan.
Just a few more seconds, still coming in.
Okay. Here's the results. Looks like most people went for C. Okay, let's move on. So let me begin with my presentation about the biomarkers. These are my disclosures of potential conflicts of interest. So let's start out with what is Alzheimer's disease. It was back in 1906 when Alois Alzheimer presented the first case of a 51-year-old woman who was confused. It progressed rapidly. She died 4 years later, and Professor Alzheimer stained the autopsy tissue and revealed the amyloid plaques and tau tangles, the abnormal protein deposits that define the disease. It was originally thought to be a rare presenile dementia because of the age of this patient, but in 1968, a group of neuropathologists showed that older adults who had so-called senility had the same plaques and tangles. So then all of a sudden we had an epidemic of late onset Alzheimer's disease instead of just senility. Now, if you look at an Alzheimer brain, obviously atrophy compared to a normal older brain, and the insets will show you where you have preponderance of plaques and tangles in different areas of the brain, the frontal cortex, temporal lobe, and so forth. But notice that in the normal brain, those insets show an occasional plaque and tangle. And it turns out that these abnormal deposits build up over a lifetime. Brock and Brock's famous neuropathological studies showed the course of the buildup and the different stages of buildup of plaques and tangles. Now, just one thing that's interesting, we tend to hear about plaques starting earlier than tangles, but the neuropathological studies that show you in entorhinal cortex very early on, you do see tangle buildup. And when I was at UCLA, we invented the first amyloid tau PET scan, BBM, and you can see from this animation of surface projections of scans of 20 subjects ranging from normal aging to Alzheimer's disease. You see the same pattern on the scans, where there's a buildup temporal region, and it spreads to other areas of the neocortex. And you find that these early accumulations of the abnormal proteins can occur 10, 20 years before disease is obvious in a clinical setting. Now, what's driven a lot of what we understand about Alzheimer's disease and drug development is the amyloid hypothesis that Selko and Hardy introduced a number of years ago, where you have aggregates due to abnormal production or decreased clearance, and you go from soluble A beta oligomers, protofibrils, and insoluble fibrils that interact with neurons, glia, and vessels. And they may induce this pathological immune, inflammatory, and cellular response, leading to neuronal death. And so this has led to targets, anti-amyloid or anti-A beta targets at the level of monomers, oligomers, protofibrils, fibrils, and plaques. And here you see a plot of various biomarkers on the vertical axis versus time, going from different stages, from amnestic MCI, prodromal, dementia stage, and whether there's positivity or not. So if you look at, say, the blue curve, this shows you where there's amyloid positivity. Neuroinflammation appears to build later than that, according to this slide, and then tau pathology, neurodegeneration, and then cognitive enhancers. And then later on, you have the behavioral problems associated with the cognitive decline. And if we look at clinical biomarkers on this kind of plot, looking at biomarker abnormality versus time, You see first is the CSF, a beta 42 abnormality, then moving to the amyloid PET abnormalities, then the CSF. So you have different kinds of cascades in these kinds of plots. And then we talk about high risk and low risk patients. And what we try to do is use these biomarkers to determine who's at higher risk versus lower risk. Now, a way in the clinic that I found helpful to conceptualize this is to think about the clinical staging, a normal aging when we're misplacing our keys, or like the case that was presented earlier, if someone is just forgetful. And then if that worsens, you see mild cognitive impairment where people are compensating for those issues. And both mild cognitive impairment and normal aging are stages when people are functionally independent. Once they need help from others, that's when dementia or major neurocognitive disorder kicks in and interferes with everyday life. And we can track the decline using lots of approaches, cognitive testing, the different biomarkers, and even FDG PET, where we look at regional metabolic decline reflecting cellular dysfunction. From a clinical standpoint, the way I conceptualize this, if we do nothing, we're going to go downhill. And we encourage people to intervene early, because the idea is it's easier to protect a healthy brain than try to repair damage once it's extensive. So no intervention here. At a certain point, someone becomes functionally dependent and they have dementia. And so if we can use prevention strategies or intervene early, we can hopefully slow down the decline toward dementia. Now, certainly genetics come into play. There are rare genetic mutations, autosomal dominant inheritance patterns, usually early onset disease, the presenilin and APP genes. More commonly, ApoE4 is a genetic risk. So it's a variant in the population, affects 20% of us. We don't generally recommend it as a predictive test, but we use it in our research. And there are a lot of genetic studies going on using GWAS and whole gene sequencing to understand the genome better. But that's just part of the picture. The dementia prevention approach was really highlighted a few years ago by the Lancet Commission. And there they identified 12 potential modifiable risk factors, ranging from air pollution to physical inactivity, smoking, alcohol consumption, and so forth. And even earlier than the Lancet Commission, we saw an important study, the Finger study, where they used a 2-year multi-domain intervention, including diet, exercise, cognitive training, vascular monitoring, in a randomized controlled trial of 1,200 older adults. And the bottom line was that this multi-domain intervention appeared to improve or maintain cognitive function at risk elderly people. So I think there they gave more traction to these non-pharmacological approach. But there's controversy in this area. Here you see a headline: 1/3 of dementia cases can be prevented within 25 years. The case for and against. And even though you have multiple pathological pathways, the evidence from the large clinical trials is not yet conclusive. And so there's still some debate in the field. Now, why biomarkers? How do they redefine how we consider dementia? Many years ago when I started out, I wrote a paper in Lancet about the dementia syndrome. And this certainly helps us look at the clinical features and how there are many potential causes. But we try to refine this with various consensus conferences and organizations getting into play to try to understand this, everything from the NIA, Alzheimer's Association research criteria, the international working groups. And you see some variation in these syndromal definitions, and then these groups have gone on to have biomarker definitions. Everyone from the FDA to the Alzheimer's Association to NIA. And there are a range of biomarkers. We can look at structural imaging, functional imaging, CSF, blood biomarkers and less invasive biomarkers. There's a sniff test, head size, and various vascular risk factors like high cholesterol, high blood pressure, and so forth. Now, one point I want to make is to differentiate between a biomarker and a surrogate marker. So biomarker can be anything found in blood, body tissue that reflects or is a sign of an abnormal process or condition or disease. Now, on the other hand, a surrogate marker is a biomarker or even a physical sign that can substitute for a direct measure of how a patient feels, functions, or survives. So cholesterol level or blood pressure, that's a surrogate marker. If you take a blood pressure, it's high, you want to lower it because that high blood pressure will predict a future disease state, a stroke or a heart attack. So a biomarker is a candidate surrogate marker, whereas a surrogate marker is a test used and taken as a measure of the effects of a specific treatment. FDA can base drug approval on the effect of an unvalidated surrogate marker, not known that an effect on the surrogate actually predicts the desired clinical benefit. And we've seen that with the anti-amyloid strategies where they've had fast track approval for these different tests. So here, if we look at a biomarker, you may see decline that correlates as you see, and then there's a new treatment and that biomarker gets better. But it may not be a surrogate marker if the new treatment, if you don't see a correlation after the treatment. This would be how you'd see a biomarker or surrogate marker follow the new treatment. So if you look at research diagnoses of these early markers, you can look at the columns, not impaired, preclinical, MCR, prodromal, or dementia. You see there's variability. So if you take, for example, somebody who's not impaired, you may not see a memory complaint. You can see a range of mini mental state scores, which can be a blunt instrument, particularly if people are highly educated. You may not see any cognitive impairment or functional impairment, and it's not clear whether there's a role for these various biomarkers. As the disease progresses, then you tend to see more of a role for the biomarkers. So here's an example. You can see the NIA Alzheimer's Association criteria versus the International Working Group criteria. And A versus T means whether amyloid or tau is positive. If you look at those scans on the top, or those cartoons of scans, you can see the red representing amyloid buildup and the other colors representing tau buildup. And the risk for progression doesn't actually increase until you have tau buildup, especially in the neocortex. And I'll get into that more with some of the other slides that I have. So here's a study that was published in Nature Medicine looking at progression to MCI. And this is in cognitively unimpaired individuals. And you see that the red represents amyloid negative and tau negative. These are cognitively unimpaired, and you don't see much progression. Now look at the amyloid, the blue represents amyloid positive, tau negative. Not much difference, but there is some progression to MCI in these unimpaired people. Much more progression even with medial temporal lobe tau positivity, and especially with neocortical tau positivity represented by the lower purple line. Now, on the other hand, progression to all-cause dementia, you can see that there's not much difference between the amyloid negative and amyloid positive if there's no tau deposition. And the same is true even if there's medial temporal tau deposition. Not much difference in progression. So you need really, in my mind, both amyloid and tau positivity to really predict that progression. And this just is another summary slide, or actually a summary slide of different pathological entities that are targeted when we look at biomarkers. And here you can see there are inflammatory markers, astrocyte markers, vascular pathology markers, a whole range. It's a real alphabet soup of markers. And here you see another way of displaying this. There's amyloid PET, a variety of approaches. The one I presented earlier, those images, that's the only amyloid and tau PET, the one that we invented at UCLA, that's for beta peer. Most of all the others are either targeting amyloid or tau. And then there are the CSF markers, not just amyloid and tau markers, but microglial and inflammatory markers such as TREM2. And then the blood plasma markers, which have gotten a lot of ink lately with the new publication that I'll just mention toward the end of this talk. But there are challenges in interpreting this, as I've alluded to. A cognitively unimpaired 75-year-old has a 40% likelihood of having an A beta positive marker. So just being at that age, there's that likelihood. Is this a disease state or is this just aging? ApoE4 carriers have a greater likelihood of amyloid positivity. CSF or plasma, A beta, 4240 tau, and p-tau. The FDA has cleared this, the CSF. CMS reimburses, but the assays will vary. So, there's a lot of issues. There's effect of concomitant medical illnesses and drugs on biomarkers and cognitive abilities. Should a positive biomarker be an indication for treatment? Depends on the biomarker, depends on a lot of factors. And there are psychological effects of learning of one's biomarker positivity. This is an issue I think has not gotten a lot of attention. I want to mention that again as I move on. So plasma biomarkers do predict cognitive decline. So in this particular study, participants with MCI progressed to dementia due to probable AD during a 4-year follow-up had higher baseline plasma concentrations of p-tau, NFL, and other markers compared to non-progression. And the best discrimination, prognostic discrimination, was observed with p-tau 181. And actually, most studies show you that tau correlates much better with clinical progression than does amyloid. Tau biomarker ratio here is the ratio of tau 217 to non-phosphorylated tau, and clinically equivalent to FDA-approved CSF tests. Area under the curve for both between 0.95 and 0.97, generally superior to CSF tests in classification of tau PET. And in cognitively impaired individuals, plasma percent p-tau 217 had an accuracy and positive predictive value and a negative predictive value approaching 90%. So here's a recent study that came out. You might have heard about. This came out in JAMA, and they posed the question: can a blood test based on the ratio of plasma phosphorylated tau, p-tau 217 relative to non-p-tau 217 expressed as percentage of p-tau 217 combined with the amyloid beta 42 and amyloid beta 40 plasma ratio, and that they refer to that as APS2 or amyloid probability score, can it accurately identify Alzheimer's disease in primary care and secondary care when prospectively applying predefined biomarker cutoff values? And notice there are issues here. They're talking about a cutoff value, and which for practical purposes, they need to do that. And they're comparing it to what primary care doctors and what specialists predict. And the biomarker won the day. The APS2 had higher diagnostic accuracy ranging from 88 to 92% for detecting the Alzheimer pathology in both primary and secondary care. So dementia specialists identified clinical Alzheimer's with a diagnostic accuracy of 73% versus 91% using the biomarker. And primary care physicians did even worse. It was 61% versus 91% using APS2. So here we see a histogram looking at a review of 14 studies that assessed ApoE4 disclosure. This gets into the psychological impact of finding out that you have positivity on these biomarker tests. And what they found was disclosure of an increased risk led to an increase in test-related distress levels. One study in this meta-analysis found that participants who knew they were ApoE4 positive had worse subjective and objective memory compared to those not informed. So subjective memory is how you perceive your memory performance. Objective is how people perform on a pencil and paper test, neuropsychological tests. And you see the differences between the immediate recall and the E4 minus versus E4 positive of those informed versus uninformed in a logical memory test delay, which is a very sensitive test according to the genotype. I've definitely seen this kind of impact in my clinical practice. So to summarize, this amyloid cascade theory, it's definitely driven a lot of diagnostic strategies, but other pathologic mechanisms are involved. For myself, I think that heightened inflammation is a big issue. And our group has done a lot of studies on intervening to decrease heightened inflammation in the brain and finding beneficial effects using both non-steroidal anti-inflammatory drugs. This in people before they get dementia, as well as spices like bioavailable curcumin, showing beneficial effects, not just on the cognitive testing over 18 months, but also on amyloid and tau imaging. So Alzheimer's disease is likely if you have positive amyloid and positive tau biomarkers present. Preclinical Alzheimer's disease is likely if you have p-tau 217 and positive A-beta PET. And this is where it's really, I think, difficult for individuals to understand that they don't feel that bad clinically, but they have the disease. And I think it creates a sense of stigma, and it's problematic. I mean, one study found, one of the ones I reviewed, that if you have just A-beta, a positive amyloid scan, and you're tau negative, the likelihood of progressing to dementia is about 1% in 3 years. If you're negative A-beta and negative tau, the likelihood of progressing over 3 years is 0.5%. So it's not much of a difference. And yet people feel quite stigmatized when they get a positive amyloid scan. Now, having said that, the biomarker results may inform us about prognosis. Again, disclosure of results may have negative psychological effects. Preclinical Alzheimer's disease trials will better define the usefulness of these various biomarkers in the next few years. So let's do our post-test case, number one, going back to this 65-year-old retired educator, seeks the second opinion for memory complaints, forgetting names and faces, misplacing glasses. Again, the last doctor ordered an amyloid PET scan. He was told he had Alzheimer's disease. He got anxious. His worries distracted him from his usual healthy lifestyle routine. He didn't have much of a problem on the MoCA test, just 29 out of 30. And he did show evidence of anxiety on the exam. And there wasn't much else in the exam that was informative. And here's the post-test. A, would you recommend ordering battery of CSF and plasma biomarkers. B, repeat the amyloid PET scan. C, educate him about the prognostic implications of amyloid PET positivity and encourage him to return to his healthy lifestyle. It'd be C. D is begin anti-amyloid monoclonal antibody treatment, or E, order a tau PET scan. And we'll see the results here. And again, the preponderance answer is educating about the prognostic implications. I mean, you could repeat the tests to see if there's an error. But I'd be more inclined, rather than repeat the test, my preference would be what most people answered, which would be the prognostic implications. I would be disinclined to start anti-amyloid treatment. And Dr. Schultz will talk about this. Some of the, there are costs and side effects of those treatments. So, the payoff may not be worth doing that. So thank you for attention. I'm going to pass this on to Dr. Schultz. Now, am I still controlling? Do you want to take on? I should stop sharing my screen.
Yes, please stop sharing.
That would be a lot easier. Yeah.
Okay, fantastic. I hope everyone can see my screen now. And as Dr. Small said, I'm Paul Schultz, Houston, Texas. Lovely to be here today. I'm going to put the chat on my left there. Feel free to write questions in there while I'm talking. I'll look at it every once in a while. And sometimes it's nice to answer questions while it's on your mind, as opposed to waiting to the end, but waiting to the end is fine. Okay. So my first case we're going to go over right now. A 75-year-old woman presents with symptoms consistent with AMCI, so I kind of got straight to the point. Amnestic mild cognitive impairment, so a real common presentation. Someone comes in and they're a little forgetful. Sometimes they notice it. Most of the time it might be her husband or a friend that brought her in. You go through the appropriate evaluation. She gets an MMSE of 27 out of 30, normal labs, an MRI with no alternative diagnoses. By the way, the lab's also no alternative diagnoses, no contraindications to anti-amyloid therapy, and has a positive amyloid PET scan. So she starts on the therapy. And then when she comes in for her third infusion, the nurse asks her about potential side effects, and she says, I'm doing fine, but I do notice a very mild headache right over here in my left parietal area. So you order an MRI before infusing her, and these are the images that result. And I'm going to show them to you. Of course, we'll go through this again at the end, and hopefully it'll be more obvious, the answer to you of what's going on here. But here's something to notice. The figure on the left is her baseline MRI, and the one on the right is at 3 months at the time that she noted a mild headache in the back on the right side of her head. Okay, this is a little higher up, so these are all axial horizontal slices. As we go up, we see area encapsulated by the blue there, and then even higher up near the vertex, we see this. And then this is a different kind of image showing something over here in the blue area, and this is a little higher up showing something again in the blue area, and a little higher up showing little black dots up above. And you may not know the answer now, don't worry about it, but by the end, hopefully you will. What do you do now with this patient? A, continue infusing anti-amyloid antibodies. B, hold the therapy and do serial MRIs. C, start steroids. Or D, start an anti-epileptic medication. And I'll let you all click your computer button there, and we'll see what people think about at this time. And as I said, we'll go through the same ones at the end, when hopefully the answer will be more straightforward to you. And by the way, thank you to Dr. Small for his talk. Very good. Really sets up understanding where the anti-amyloid therapy comes in and how you're going to pick out the patients to whom you'll be giving the therapy. And that is the ones that have the biomarker positivity that he mentioned during his talk. Okay, looks like we're ready there. Okay. So it looks like, let's see, 3 people, 16, 6, and 2 for the 4 answers there. Very good. Okay. So again, we will come back to that at the end and see what, if it changes our thoughts at all. Okay. So, not too much in the way of conflict, I don't think. As Dr. Small mentioned, it was 118 years ago now that this German neuropathologist identified pathology in the brain of Augusta Dieter, who passed away in the 50s. And as Dr. Small said, he drew pictures of what he was seeing under the microscope and really identified some of the major hallmarks that we now think of with Alzheimer's. Amyloid plaques outside of cells, and actually the plaques are much bigger than the cells. And then within cells, he saw these aggregations that we would now call neurofibrillary tangles. I'm not sure whether he identified inflammatory cells around the plaques, but that would be the third diagnostic or pathologic hallmark of Alzheimer's. And then further downstream, there's vascular changes, there's releases of free oxidants and so forth, which you wouldn't see on pathology slides. But the main initial event is amyloid deposition, followed downstream by all of the other items. It wasn't until 1984, 78 years later, that we got any inkling of what was going on in the plaques. The week that I graduated from med school in 1984, 2 very smart chemists, Glenner and Wong, were able to finally solubilize amyloid plaques. They're very chemically sticky, and these 2 chemists figured out that in high-dose formic acid, they could chip off a few amino acids from the end there, and then they went and looked through what was a primitive library in 1984, and they found that these 42 or 40 or 38 amino acid peptides that were part of the amyloid plaques came from a large protein that was present in the presynaptic terminals of many cells in our brain. And that protein was not named or not known. So they said, well, it's the precursor to the amyloid plaques. So we'll name it the amyloid precursor protein. And that was all 1984. And that was really big because now for the first time, we had a target of something going on in the disease that might be relevant or might not be relevant. We weren't sure at the time, but at least we had something to sink our teeth into. Now, it turns out that this protein present in many cells of our brain is cleaved by an alpha secretase, it's called, in response to certain signals. And then the large preponderance of the molecule, the APP alpha, it's called once it's cleaved by that, that goes floating around, and it's an intercellular signaling molecule. It tells cells all around the area what's going on in my cell over here. Now, every protein in our body at some point has a life expectancy that's met, okay? And it turns over. We metabolize it. We use some of those amino acids to make new proteins, and other times we have to go out and eat a hamburger or a steak to get new protein in our body that we can make into new proteins, okay, by breaking down and building up. Well, this one is no exception, the amyloid precursor protein. And this 752 amino acid molecule, as it's being broken down, is often cleaved at this point and this point, leaving 1/20th of it, which is about 40 to 42 amino acids in length. And it's very chemically sticky, though. And we're all making this, it turns out, at about the same rate. Everybody on the call today, even people in their 30s, are making it at about the same rate. What happens, though, is that if we don't get rid of it fast enough, And by fast enough, I mean a difference of about 10%. So we have a half a dozen ways of getting rid of it. If any one of those 6 isn't working real well, and we're getting rid of 10% less, then over decades, the monomers stick to each other and become oligomers and protofibrils and fibrils and then amyloid plaques. Okay? We think that's the genesis. And as Dr. Small said, we can see sufficient amyloid plaques on an amyloid PET scan up to 20 years before someone comes in with their first symptom of MCI or Alzheimer's. Okay? So this process goes on for decades before someone comes in. And it's probably longer than that, but that's the point where there's enough plaques, we can see them on a scan. Okay? Now, in a couple of slides, I'm going to get to the therapies, but I wanted to use this picture we were just looking at as an opportunity to say there is a bunch of states of aggregation, anywhere from monomers to plaques, and we have been testing antibodies against each of those forms for the last couple decades. And it's even more subtle than that. Within each form, there's some antibodies that bind to the N-terminal, the C-terminal, the middle. There's antibodies that cross the blood-brain barrier more or less. There's antibodies that turn on the white blood cell system when they bind more or less. We've tried different concentrations of antibodies, all kinds of stuff. And the net effect is that after 30 years, literally 30 years of doing this, because the first immune therapy was 1992, was an active immunization. Since then, we've been doing passive immunization. And after 30 years, two and a half of these antibodies have had positive phase 3 trials. And that'll be the focus of the treatment aspect of this morning's talk. Okay? Now, as Dr. Small said, someone comes in to see you, they have a picture that could be related to early Alzheimer's, MCI. You do the lab work, it's negative. You do the MRI, you don't see stroke, tumor, abscess, infection. How do you know then, though, if this person is a good candidate for anti-amyloid antibody therapy? And the answer is they got to have a lot of amyloid. Okay, that's what it's targeted against. So if you do an amyloid PET scan and don't see anything, they wouldn't be a good candidate. If they have frequent neuritic plaques, which is the pathologic definition of Alzheimer's, then they would qualify. How are you going to know during life if they have frequent neuritic plaques? Well, enough amyloid and tau gets into CSF that you can measure it there, as Dr. Small said, or you can do an amyloid PET scan. And that's what I'm showing you here. You may or may not have seen these before, so I thought I would show one. Over here is a negative one, and it's negative because the tracer is hanging out in the deep white matter. And that's normal because we give the tracer intravenously. It's just a little couple cc's of what looks like water, goes through the body, goes through the brain, washes out, and at 30 minutes after injection, we put them in the scanner. The stuff washes out of the white matter more slowly. So if you just see it in the white matter, that's a negative amyloid PET scan. But if you look over here, this is a horizontal slice. This is from the side, there's the nose. This is from the front, and their ears would be there. If you look at these images, and you see darkness in the gray matter, so this is the skull, this is the gray matter right under the skull, and then the white matter. If the gray matter looks like the white matter, those would be positive areas, and that means that the tracer has stuck there after it should have washed out because it sees amyloid plaques. How many plaques? Frequent neuritic plaques. If there's just a few plaques, it washes out, and you have negative in that area. So this would be positive. This would be a person that would be a good candidate for anti-amyloid therapy. Now, let me mention that the whole approach here was started by a guy back in around 1990, 91. I'm sure Dr. Small remembers him. I think he was with Elon Pharmaceuticals, very smart guy. He got the idea, how are you going to get amyloid plaques out of the brain? You can't go in there and dig them out. It's not like a tumor where a neurosurgeon can get at them. You could make less of them, and we've tried that over years. We've found chemicals that cause less amyloid to be deposited, but they've had a number of side effects. he got the idea, what if we immunize someone against amyloid? And that turned out to be really effective. His first trial that some of us were in back in 90, 91, I think it was very effective at getting amyloid out of the brain. We immunized someone with amyloid, beta, the 1 to 42 molecule, and an adjuvant. It got rid of it. But the problem was that the immunization caused a lot of inflammation in the brain in some people. So 6 out of 360 people actually had encephalitis, and we couldn't turn it off. And so Dale Schenk was his name. It took me a minute at this age to come up with it. A real smart guy, passed away just maybe 2 or 3 years ago. So we decided that active immunization was not a good way to go. You can't turn it off if there's a side effect. That led to the whole idea of using passive immunization, meaning we make the antibodies in the lab, we give them to people regularly, they wear off, you give another dose, they wear off, you give another dose. That's the downside. You got to give dosages. The upside is if there's inflammation, you just stop giving the antibody and it goes away. Okay? That was the big breakthrough. And then it took 30 years to find antibodies that actually got rid of it and so forth, for all the reasons that I mentioned earlier. They had to have the right target, apparently, the right concentration, all that. Lecanemab was the first one to cross the finish line in a phase 3 trial. Phase 3 trial means large, placebo-controlled. It's the kind that the FDA will look at and say, yes, you've got enough efficacy that we can improve it, and the safety profile is good. Okay? And I'm going to say just a few details about this trial. It was phase 3, as I mentioned. Age 50 to 90, that's good. The donanemab that I'll talk about, great drug also, but it's a narrower age range. So if you have someone who's at the 50 end or the 90 end, lecanemab may be a better option for them than donanemab. Primary outcome measure is this beast called the Clinical Dementia Rating Scale. If you've never seen it before, don't worry about it. We developed it around that same time in the early 90s because we needed something that was reproducible and that looked at cognitive measures and activities of daily living and so forth. Because up till then, we were just using the MMSE, and the FDA rightly said, hey, if they're 3 points better on the MMSE, what does that mean in the real world? And the answer was we didn't know. So we came up with the CDR. Actually, someone had invented it, but we validated it as part of the Alzheimer's disease cooperative study and showed that it was a useful test. It's reproducible between people, reproducible over time, and it's very accurate for following clinical outcomes. And that's why it was used in many trials, including this one, because of that. Now, at the same time, we do other measures that you can relate to in real life, like the MMSE. And it's important to know that this trial had a fairly just below normal MMSE of 25.5 in the placebo and the treated groups. CDR, for those who actually know anything about it that I was just mentioning, the sum of boxes was 3.17 and 3.2. And if you don't know what that means, don't worry about it. It's not important. And then on the amyloid PET scans, we measure the actual amount of pixels that are positive. We call that centiloids of positivity. How many is there? It's a quantitative measure. And we can also do it with different tracers. And it's only important to know that it was a modest to moderate amount of amyloid in the brain in people in this trial, 77.8 and 75 centiloids in the treated and placebo groups. Okay. One dose, 10 milligrams per kilogram every 2 weeks. It turned out that in people we tried ramping up the dose and all that, it made no difference at all in side effects. It turned out that just going straight to the full dose every 2 weeks was a positive outcome. So this shows some of the primary data that came out of that lecanemab trial that was published now 1.5 years ago. The CDR sum of boxes, this 1.5-hour, 2-hour test that I was mentioning, 3 cognitive measures, 3 sort of activities of daily living type measures, showed a decline in progression of 27% in the lecanemab group versus placebo, okay? The ADAS-Cog14, which is a commonly used cognitive test for trials, you don't use it in the real world, so don't worry about it. But that's kind of like a really glorified MoCA is what I would call it. for those that know about 27% difference, very similar numbers. The antibody lecanemab is against the protofibril form, okay? So it's midway between monomers and plaques. So despite the fact that it's against protofibrils, it's actually quite effective at getting rid of plaques. So apparently the stoichiometry is such that if you really get rid of the middle guy there, the plaques end up dissolving, even though they've got a very high affinity constant there, okay? So by the end of 18 months, there was a drop from, as I mentioned, 75, 78 centiloids at the beginning of more than 50 centiloids. So the majority of people at the end of the trial had a negative amyloid PET scan, or almost negative PET scan, okay? Now, activities of daily living, we have a special scale for that, ADL scale. It's for people with mild cognitive impairment that was also developed as part of the Alzheimer's disease cooperative study. And 45% slowing in activities of daily living loss in lecanemab versus placebo group, okay? ADLs make a really big difference in people's lives. For example, my wife can't go to work on Monday if I have MCI and I don't know how to use my phone if there's an emergency, or if I can't make a sandwich, you know, that kind of stuff. So this is a really important outcome measure, and it slows it by almost a half. Now, this is data that is now public, but I don't have slides for it because it hasn't been, as far as I know, it hasn't been published in a place where I could, but I've seen the slides and I wrote down the values. And since it's public, I think I can say it. And that is, oh, and these are subset analyses, not pre-designated analyses. So if you're a statistician, you want a primary outcome measure and you believe that. Everything else you can analyze all you want, but the statistician will tell you to interpret it cautiously, or you know, don't bet the farm on it. Okay, so we'll take that caveat. But in doing subset analyses, you know, here Eisai said, well, okay, the enrolling criteria were MMSEs of 22 to 30. What if we just look at the people that are very early, MMSEs of 27 or greater? It turned out that they slowed not by 27%, but by 60% over the placebo-treated group. And then in what I think is kind of shocking, but really interesting, and you know, I hope it's true. Again, we can't say it's true because it wasn't pre-specified as an analysis, but a subset of people in the trial got tau PET scans, and so we could quantify it. And it turns out that even though everybody in the trial had to have about the same MMSE and cognitive scores and all that stuff, the amount of tau in the brain varies a lot between people. And they were designated as low, medium, and high, okay? Low is biologically thought to be earlier, okay? High MMSE is cognitively earlier. Low tau is thought to be biologically earlier, although it's not 100% correlation between the two. Okay, so if we look at just the low tau people, what was found? The controls, actually, 28% of them showed improvement in the CDR over 18 months. And all of you that see patients know that people vary from time to time. So 28% were a little bit better after 18 months. Okay, we see that. It could be the luck of it, or it could be that maybe they had something else going on that was affecting their CDR, like maybe depression or something else, who knows. But anyway, it is what it is. 28% of controls got better, but amongst those on lecanemab, 60% got better. And by better, I mean like 1 point on the scale. I see this in clinic. I don't ever tell patients this because I don't know who has how much tau. Insurance now won't allow us to get tau PET scans on people we're putting on lecanemab. So I don't know who has what. But my fellow, I'll never forget, a few months ago said to me, hey, I've got 2 people this week whose CDRs are better than they were at the start. And sure enough, we do see that once in a while. Again, this is a small subset of the original patients because only a third got tau PET scans, and then this is a low tau, so it's a third of a third. Okay, so we don't want to bet the farm on it, but we do see people, certainly the primary outcome was slowing of progression by 27%, maybe 60% in this subset, and maybe even improvement in this subset. Okay, exciting, again, but we can't bet the farm on it yet. It means we're slowing the course of the disease, but I wouldn't I wouldn't by any means say we've cured it yet. That's down the road. Now, this is the second drug that made it through phase 3 studies, and the publication of it was from last summer, a year and a week, 2 weeks ago. And this was on the Lilly product, donanemab. I don't know if Dr. Small was involved in this. We were in Trailblazer. We still have people in it because even though the trial finished, we follow people after the end of the phase 3 trial. So I can kind of see myself what's going on the patients in my clinic, as well as knowing the numbers that came out of it. Now, normally I don't like to give a lot of the entrance and exclusion criteria because it's kind of boring, frankly. But here I'm going to say just a few things. And the reason I'm doing that is that we now have 2 FDA-approved medications. And so the first thing people say to me is, which one do you want to use? So I can tell you I've used both of them a lot. I've got 75 people on lecanemab as standard of therapy, and I've still got maybe 40 people on donanemab as part of trials. It's approved by the FDA, but we're working through the paperwork to be able to give donanemab as standard of therapy. But people say, how do you like them? The answer in my mind is I like them about the same. They look very similar from where I sit. Now, I'm doing my impression as opposed to a phase 3 study, but that's my impression. But my impression is also that the 2 trials are very different. And I think that if there's any subtle differences in outcomes, it's probably due to that. Number one, the MMSEs were not 22 to 30, it was 20 to 28. And instead of the average being 25 and a half, they were 23 in the donanemab trial. Okay, so 2.5 points further progressed in the donanemab trial. The CDR scores, global scores, I didn't tell you, it was 2/3 here, 0.5, 1/3 a global scale of 1. That's a slightly worse than the lecanemab trial. And in terms of the amount of amyloid in the brain, remember it was about 75 in lecanemab trial. It was 102, 103 in the donanemab trial. So biologically further along, a lot more amyloid in the brain. Despite these differences, though, I'm going to show you that clinically the 2 drugs came out remarkably similar in terms of their outcomes. Okay. Now, donanemab, one difference is that we give a half a dose 3 months in a row, every 4 weeks. And then after the 3rd one, if the MRI is okay, we give the full dose of 1,400 milligrams once a month. Lecanemab is 700 milligrams twice a month. So it's the same exact amount of antibody, different antibody, but same amount. But one's given half every 2 weeks and one's given full once a month. That may also have something to do with differences in side effects, although honestly, I think it has more to do with the stage of the patients than how we're giving it. But, who knows? That I can't say that with certainty. Now, this is the primary outcome measure, just like we looked at with lecanemab. It's a different outcome measure, IADRS. It's a combination of a clinical measure, the ADAS-Cog14, and the activities of daily living, those 2 together, okay? 35% slowing in the low medium tau group versus 22% slowing in everybody, the combined population. Now, this was a pre-specified analysis. This is one of the unique features. I'm not saying it's good or bad, but the unique feature of the donanemab trial is we specified ahead of time we would have a low medium tau population and a low medium high tau combined, okay? You can see by the difference between these, the high tau obviously the drug did not have as much of an impact. Otherwise, this curve would be the same as that curve. And they're different. This one's less. That means that the low medium tau did better than the high tau. The high tau still had a positive outcome, just not as much, okay? Now, this down here is important because this is a secondary outcome measure in this trial, but it was the primary in lecanemab, and then we can compare apples to apples. Over here, we have the low, medium, and high tau populations, 28.9% slowing of progression. Remember, it's 27% for lecanemab, basically identical. Okay, so this is comparing apples to apples. They both had the same effect on the CDR slowing. And over here, in the pre-specified subset analysis, it's low, medium taus, and we can see it's about 36% slowing. Again, arguing that people that are biologically earlier, low, medium tau, do better than people who are high tau. Now there was one other very important difference in the methods between the donanemab and lecanemab trial, which are going to end up having implications for us giving the treatments and for us having to make a decision about what to do. So let me just briefly tell you what that is. And that is that we did amyloid PET scans, not just at the beginning and the end, but also at 6 and 12 months. So 0, 6, 12, 18. If at 6 months, people had a negative amyloid PET scan, which was true in 17%, we stopped the therapy. At a year, if people had a negative amyloid PET scan, which was 47%, we stopped the therapy. So these plots here are actually people who everybody went to 6 months, but after that, 83% went on. And then at a year, another group dropped out so that only 53% went on after that. So these data, even though they're almost identical to lecanemab, a lot of people, half the people weren't on the drug for the last 6 months of the trial, okay? It's neither good nor bad, but it does make the potential argument, and I think this is left to be decided, the potential argument that you could stop the therapy after 6 months, 12 months, or 18 months if a person has a negative amyloid PET scan. And that's a unique feature of the design of this trial. Now, this figure is just, don't worry, I'm getting near the end here. This figure is just to tell us that this donanemab is an antibody specifically against plaques, okay? Lecanemab, remember, was an intermediate protofibrils. This is against plaques. It's very effective at getting rid of plaques, okay? Again, they started at about 100 centiloids. By the end, most people were about 15 centiloids, a drop of 85. So they were a visually negative amyloid PET scan. Again, it was, I think, 79% were negative and 21% had a little bit of residual, okay? Now, this is also true for lecanemab. I didn't mean to not show this there. But the downstream markers are pretty interesting. So both drugs are anti-amyloid, getting rid of plaques, getting rid of amyloid, having an effect clinically. But one of the questions we have as scientists, and also we're wondering because, what happens to the downstream stuff? Amyloid, yeah, we see that for 20 years, but 15 years before symptoms, we start seeing tau. Then we see inflammation, then we see vascular disease and everything else. Well, one of the markers that Dr. Small was talking about was p-tau in blood, okay? And it turns out that the p-tau in the blood with donanemab, and I didn't show it with lecanemab, same thing, they both went down. That's a marker of phosphorylation of tau at the 217 mark. That's fairly specific for Alzheimer's. So this means that getting rid of amyloid from the brain not only is helpful clinically, but one of the reasons may be that biologically, we're actually improving the next marker in line, which is phosphorylated tau in the brain, which, as Dr. Small said, may actually be the bad boy that results in neuronal dysfunction and loss through other mechanisms downstream, okay? So it's very reassuring that downstream markers are changing. They're not zero, but they are changing. Now, of course, in the serum, you're not going to see a zero anyway. You'd have to look at the tau PET scans for that. This complicated looking slide is just so that I can tell you again, if someone asks you, there are differences in the way lecanemab and donanemab trials were done. And for those of you that remember aducanumab, for that also. 2 of them use CDRs, 1 used IA-ADRS. They were at different stages of the disease. The aducanumab was the earliest, lecanemab middle, and donanemab further along in terms of the CDR measure, and also in terms of the MMSEs, 26, 25.5, 23. ADLs, higher number is worse, so 66 is worse than 41, and the amyloid burden, 102 and 77. Again, this is just to make the point they were done differently. That may have something to do with side effects, but in terms of clinical efficacy, as I showed you, they're basically very similar to each other, dead ringers. I see people in clinic on both of them. They both do much better than controls, or by that I mean people that I saw for the first 30 years of my career who just inexorably progressed, and now I see people not doing that. And this slide, again, looks a little complicated, but it's just to say The slowing on relatively comparable measures are 25, 27, and 29%, basically the same, okay? And if we look at early people, cognitively, about a 60% slowing by both of these. And then if we looked at low tau levels, there were some people who actually got better. It wasn't looked at in this study, as far as I know. So it doesn't mean that it didn't happen there. It's just, but it's useful to kind of know, again, that the main outcome that I'm talking about today is slowing by 27, 28% in everybody, but there are subsets that may do better than that, although I can't say too much about them conclusion-wise because they are subset analyses. And this is the slowing of activities of daily living. Okay, now I'm going to talk in my last couple slides about the 3 big side effects to know about to safely treat your patients and reduce the risk of them so that your patients do well. Okay, the first one is infusion reactions. These are antibodies not made by my body or yours. So when I give them to a patient, anywhere between 9 and 32% of people's bodies recognize them as not being part of their own makeup, okay? For donanemab, it's about 8%. I guess I should have said 8 to 32. For lecanemab, it's about 26%, okay? A little bit different. Again, the IRRs are not that big of a deal. They are, there are side effects, but they're not that big. So the difference in rates there, it's important because I have more of this with lecanemab than donanemab, but they're both treatable. So I don't really consider this to be a big difference between the 2 drugs. The big thing to know is it's usually on the first infusion, less so on the second, less so on the third, and very rare after that. So you're doing your 1.5 years of treatment. It's really just the first few that you have this, okay? What do you see? The majority of people, and again, this is 8% or 26% in donanemab, lecanemab, they'll start to tell you, I'm starting to feel like I have the flu or something. I'm getting a little fever, little chills, a little achiness, a little headache. That would be common. Skin itching and blotching, second most common. Very rarely confusion delirium. I list it here because we see it in the trial, but I've never seen it really. Shortness of breath, I've had 1 or 2 people, not with these antibodies, but with other ones we've studied, they start getting short of breath. I've never, thank God, had someone have anaphylaxis, but I know with donanemab, there were 4 people who had varying degrees out of 859. 4 had varying degrees of anaphylaxis, and I don't remember the number with lecanemab. The big thing, though, is that all of these are treatable. What do? My nurse immediately gives them a Tylenol, acetaminophen, and a Benadryl if they have it. And then in a few minutes, if they're still distressed or they're getting more, she gives them a shot of Decadron. And 99.9% of the time, that's it. 10 minutes later, they're fine. If we've had just a couple people over the years, not necessarily with these antibodies, their blood pressure start to go down a bit. She gives them half a bag of saline. That usually takes care of it. I've had one guy in my career, we had to lie him down, and then his blood pressure was immediately normal. I've never had anaphylaxis, but it's been reported. So if you're going to give these drugs in your clinic, in addition to these drugs, have EpiPens available. God forbid something ever happens. Thank God I've never used them. They expire and we get new ones, but we've never had to give it to anybody. Now, if someone gets this on the first one, because they could get it on the second or third one, what I do is I prescribe oral treatments for them. I say, starting 2 days before you come to see us, start taking Tylenol, Sertrazine, or any antihistamine you want. And sometimes we'll give them a Medrol dose pack kind of thing, like 16 milligrams a day times 4 days. And after the third infusion, we just taper that. This takes care of about 99.5% of people's. So you give this to them before they come to see me, and then they don't have the IRR, the infusion reaction, okay? I've had one lady in my entire career who still had it, and the next time we just gave her bigger dosages of these, and then we were fine. So we take these seriously because there is a few people out there who are going to have anaphylaxis, okay, just like any drug. And we want to be prepared for that. But I got this off the UCSF website. While IRRs can be dangerous, the majority have been easily treatable and not severe. And that I would agree with that 100%. We take care of it, we see it, we're done with it. The other 2 side effects to know about, ARIA-E and ARIA-H. ARIA-E is what? It's amyloid-related imaging abnormalities type E, which means edema. It's called that because about 12, 15 years ago, we didn't know what this was when we saw it, this ARIA stuff. And we figured out we were seeing it in people who had amyloid in the brain. And it would often be in areas with a lot of amyloid. So we called it an amyloid-related imaging abnormality. And some people actually got biopsied, and we figured out that this is actually edema. It's, swelling, it's plasma, water, whatever. So we called it type E. This is one of my patients. This is her baseline MRI horizontal slice right up about high ear level. This was like after the third infusion. And we look at that and say, okay, you got some swelling here. And then a month later, so we stopped the infusions. And a month later, this is what her MRI looks like. And then a month after that, this is what it looks like. So it's almost back to what it was there. So there's a few things to know here. It often doesn't peak right away. Number two, this woman had no symptoms at all. Okay, so what's happened is that we've all gotten a lot more conservative, and what we're doing now is very regular MRIs, even if they have no symptoms. And that way, more than 3/4 of the time, we pick this up before they have any symptom. So risk mitigation strategy, do lots of MRIs, pick this up before they have significant swelling, and stop the infusion and let it go away. 1/4 of the time, they will have symptoms, like the case I presented. She came in, she says, I have a mild headache. And it's really interesting in this case here that we're looking from the feet up. So this swelling is right here. The person will say, I got a mild headache. It's not really bothering me, but it's right here. It's not a muscle contraction headache. It's not a migraine on the left side. It's right there. It's just a dull pain. And I'll say, oh, we're not infusing you today. We're going to send you for an MRI, and then we'll see this. And I tell them we're going to do them once a month. When it goes away, we'll start again. 3/4 of the time, when you start it again, they never have it happen again. 1/4 of the time, it happens again. Now, this is really important to know, and that's the following. And that when you see this stuff, if it's back here in the left occipital lobe, often no symptom at all. If it happens to be in the dictionary over here of nouns and verbs, they could have word finding issues. If it's higher up in the motor strip, they could have a weak arm on the right side. It could also, by the way, cause a complex partial seizure because it's right below the cortex there. Very rare, but I've seen a few in my career. I think 2 or 3 of them. But the point is that there could be, so if what I tell my patients is we're going to do these routinely, but if you have a weak arm one day, don't call me and get an outpatient MRI 3 days later to rule out ARIA, which is probably the cause of it, because it could also be a stroke, right? Anybody could have a stroke. And these are all people, average age of 73 or whatever. So the stroke could happen. And so we get a stat MRI to rule out a stroke or to differentiate it from ARIA. This picture here is to show you that this person did not have a stroke. For those of you that are neurologists that are used to seeing people with strokes, the ADC and DWI images look for what's called restricted diffusion. That means you've got swelling, and the swelling is such that the water molecules aren't moving around. That's what you see in a stroke, okay? The stroke, the running out of ATPs in the gray matter causes them to get edematous, and the water doesn't move at all, and the radiologist calls you up and says the ADC and the DWI are positive, and so it's a stroke, okay? Or, in this case, I pull up the films, and I look at it, and I say, okay, if it's white over here, and white over here, that's not restricted diffusion, that's ARIA-E, and that goes along with this, okay? Now, if this is white and this is dark, that's an actual stroke, not ARIA. They should be a candidate for TPA, whatever you're going to do. Now, the mitigating factor nowadays with ARIA is that sometimes you see this, okay? This is ARIA-H. It's ARIA, but it's H meaning hemosiderin, hemoglobin, heme, okay? These are microhemorrhages there. This is a different kind of pulse sequence of MRI, SWI image, and sometimes your radiologist might get a gradient echo. And you'll see these little black dots there. Those are microhemorrhages, okay? There's rarely symptoms from them, but they get us all nervous. more nervous than the REE. The REE comes and goes. The REH, though, stays. But the big thing is that a certain number of people with Alzheimer's will have a big hemorrhage each year anyway, because that's part of Alzheimer's disease and the amyloid deposition in blood vessels. And when we see too many of these, we get worried that they might be at risk for a big one. And so if we see too many of these, we just stop and don't restart the infusion. So this is just a list of other things to know about ARIA in the real world when you're practicing. Again, for REE, only a third have symptoms, and that's true nowadays because we get a lot of MRIs and we pick it up before they have symptoms. Headache, as I mentioned, is common. Once in a while, dizziness. Once in a while, someone says, I feel a little dingy, I just don't feel sharp like myself, or I'm walking a little wonky, or I've got a weak right arm or something like that. That could be REE. We get a stat MRI. If it's focal, if it's not focal, like just a headache, we just get a regular MRI and confirm that it's REE and hold the infusions. REH, less than 2%. We list 2% as having symptoms, but the truth is that the REH is always mixed in the REE. So a lot of us think the REE is what's actually causing the symptom, but to be a purist, we say, okay, maybe 2% had symptoms. The clearance is just like the woman that I showed you. About half the people get over it in 3 months, 80% by 4 months, okay? So you just do serial MRIs. Somewhere between 1 and 5 months, they're usually negative for REE, and you can start infusing again, as long as there's not too much REH. If there's too much REH, then you just don't start again because we don't want to take a chance on causing a large hemorrhage. Treatment, usually it's none, but if there's a lot of REE, all of us get nervous. We often give steroids. It is probably vasogenic edema, like what you see around a tumor or an abscess. And so steroids may be helpful. So sometimes we give them if there's a lot of it. The few cases in my career where I've seen complex partial seizure, I give antiepileptics. A couple months later, I often stop it. And then, of course, supportive therapy. In the treatment trials for lecanemab, donanemab, they're both very similar. About 30 out of 895 were stopped due to either the IRRs getting everybody nervous too much, which is fine, and a couple of them did have hypersensitivity reaction. If people meet criteria for too much REH, then we stop. And of course, anybody who had a hypersensitivity reaction, we never give it to again. So the bad news is we do have to stop it in 30 people out of 900. But the good news is by doing that, we prevent more side effects. And this gives you an idea that most people made it through the whole trial without having to be stopped. And this is just to tell you another really important point, and that is that the ApoE genotype is a big risk factor for who has ARIA and who doesn't. With lecanemab, if you do not have a 4, REE is 5%. If you have 1 4, it's 11%. 2 4s is 33%. And with donanemab, very similar, slightly higher numbers. Okay. For REH, it's the same kind of thing. Big difference by ApoE genotype. Notice, though, that even the placebo group, they leak a lot. The ApoE4s have a lot of microhemorrhages and superficial siderosis. 1 out of 5 will have them anyway, and 2 out of 5 will have them when we treat them. Again, we mitigate risk by, if we see too many of these, we just stop and don't take a chance on people getting worse. Okay, this I think is a very similar number, so I'm going to go past it and just give you, this is probably the most important slide in terms of side effects, and that is what we've learned over the years to reduce the risk of side effects or the risk of them being long-term, okay? We've learned a lot of things before we even got to lecanemab, donanemab, and we showed with them that the strategy worked, and then we made some more modifications. Okay, so what do? Number one, we do frequent MRIs with any of these drugs, and we ask about symptoms every time we see them. About 25% who develop REE will have a symptom. The other 75 don't, okay? Now, we don't start either of these therapies if they have more than 4 microhemorrhages at baseline, okay? They got a few of those, that's someone who's going to get a lot of them on their own, and we don't want to be part of that. If they have more than 1 centimeter of a hemorrhage at baseline, we don't start these drugs. If they have an aneurysm or an AVM, we don't start them. God forbid you pull cause inflammation in the blood vessels of an aneurysm or an AVM, that could cause a big hemorrhage. So all of these are things we do to rule out people that are likely to have a hemorrhage. And then if they have more than 2 areas of superficial siderosis, that's a hemorrhage on the surface, we don't start the drugs. And nowadays, if they're on major blood thinners, we don't start the drugs. The truth is, we've had a lot of people over the years who are on Pradaxa, Xarelto, Eliquis in these trials, but we finally decided with lecanemab that there were 2 people who had hemorrhages who were on these out of 79, none in the donanemab trial, but that's 2 out of 160. We don't know if it was because of the drug itself, Pradaxa, Xarelto, or combining that with this medication. So we just as a group decided, just don't give these drugs if they're on a major blood thinner. It's just not worth you and I losing sleep over our patients being at risk. And then after we start the treatments, if they get more than 10 new microhemorrhages or more than 2 superficial sideroses, we stop it. Aspirin and Plavix don't seem to make a difference, so that's okay. Not enough people have gotten TPA for us to know what to do, but I think all of us have gotten really cautious and said, you know what? If they've got a major stroke and they're going to have a lot of morbidity, okay, TPA may be a good idea. But if it's more minor than that, I would stay away from TPA because we just don't know if someone who's got potentially leaky blood vessels getting TPA could have the hemorrhages we already see with TPA under the best of circumstances, okay? So just about done now. This is just to tell you that we do regular MRIs. I've mentioned that verbally. For lecanemab, the recommendation is 0 after 2 months, after 3 months, and after 6 months, okay? And then you can also do them anytime you want if they have a side effect. And this is my second to final slide, just to tell you, today I've been talking really about getting rid of plaques, amyloid plaques. And I'm doing that because it's the first 2 drugs doing that had positive phase 3 trials that are slowing the course of Alzheimer's. There are other ongoing studies of other ways of dealing with amyloid. We and maybe Dr. Small, I don't know, are doing anti-tau trials. There are other people doing anti-axonal damage trials, not us, anti-synaptic dysfunction. I have 3 inflammation trials, anti-inflammation trials. I have several for renormalizing the lipid profile. And the point of it is that amyloid is the first step, perhaps, but tau, changes in synapses, changes in neuron numbers, inflammation, lipid changes, vascular injury, all of those are part of the disease. And it may be that they're all important, and that may be why so far we haven't cured the disease with just an anti-amyloid plaque approach. They're doing better, but we haven't cured it. And so we're doing trials with all these other ones to see if maybe we need to add something onto them in order to really stop this disease more in its tracks. And this is just to tell you that Dr. Small showed this slide, this is my final slide, that people come in way over here with MCI and then develop dementia, but all the pathology is going on for 10, 20 years before that. So I have 3 trials of people back here, no symptoms, but who have significant amyloid in the brain as determined by amyloid PET scans. And we're seeing if we can't reduce the risk of those people going on to develop Alzheimer's disease. So that's the end of my talk. Thank you very much. And I think we made it in time for the Q&A in the last few minutes here.
If we could do that polling real fast.
Oh, sorry.
Yeah.
Oh, yes, the final slide. Yes. Yes. Well, hopefully you all got smart by what I talked about. So we have this lady. She's a perfect candidate. She gets started on the therapy. And what do we see over here? ARIA-E, right? That looks like what I was showing you. She's got 3 areas of it. We would say she's severe. She's got 3 areas of 5. We will call this severe, even though she has no symptoms. And she has some ARIA-H here, ARIA-H and ARIA-H. So knowing all of that, would you continue infusing the antibodies, or would you hold them and do serial MRIs until it clears, or would you start steroids, or would you start a seizure medicine? Go ahead and do that. And by the way, someone wrote in the chat, we're being told, advised not to use MMSE. Yeah, MMSE is a very blunt tool, and Dr. Small probably will affirm that. But for clinical use of these drugs, the insurance companies want to know the MMSE because that was something they could point to and say they qualify or don't qualify. So I do the MMSE not because it's a good diagnostic test, but because insurance requires it. But the CDR, the MoCA, slums, those are all good ways to diagnose your patients. Okay, it looks like we got, yeah, very good. So all of you were listening, 16 were listening very carefully. We would hold the antibodies, do serial MRIs. Now, the truth is this woman has so many microhemorrhages, we wouldn't restart her. So I would tell her, we're going to do serial MRIs to make sure everything calms down and you don't have any more bleeds, but we're not going to restart it. If she had symptoms from the swelling, then we could start steroids. If she had complex partial seizure, we could start that. In the old days, we used to power through. We didn't know what this stuff was, and we kept going. But nowadays, we would say this is really one of the big messages today. Use the drugs because they're efficacious, but stop them if you have side effects so that we don't take a chance on adding fuel to the fire. And by doing that, our patients will be safe and we'll have very few people with any long-term side effects. Most people go through very well. Okay. Any other questions? You can either, I think you can unmute yourself. It's up to Brian. He's our MC, or you can type in the chat if you'd prefer.
Yeah, there's one in the Q&A box.
Yeah. Yeah. No, good question. No, that makes us very nervous now. Even if the anticoagulant is for a DVT or atrial fibrillation, whatever it's for, I just tell them, once you get off of that, come and see me and we'll start this drug. But we're not going to do it during that. The truth is, a lot of people have gotten the treatment on anticoagulant, but it just makes us too nervous. We call it the acceptable use criteria, AUC. And the AUCs voted on by everybody who works with dementia is that we won't give it. What dosage of steroids? Oh, yeah, you can use a steroid dose pack. You could give, I do that. I just call in a steroid dose pack, or I just lengthen it out because it often doesn't go away in 6 days like that. My nurse uses, I think it's 4 milligrams of IV Decadron, but when she prescribes it for outpatient, I think it's like 16 of prednisone, something like that. So not a big dose, but enough to help with the, how to get a certificate. So Brian will tell us how to, and I think Dr. Small mentioned earlier to go on the website and get the your certificate, your CME certificate.
So before we close, Paul, I have a question.
Mm-hmm.
So interesting to me that you see the tau go down. Do you, it could be, I guess we don't know the mechanism. It could be a direct effect of the antibodies, or it could be related to the reduction in plaque accumulation. Do you have any hunches about that?
Yeah, that's a really good question. That's the key biologic question. What's going on downstream and why? And those are both very plausible hypotheses without knowing the data for sure or with any certainty. And we haven't done any biopsies. I think we have to say we don't know, but that's certainly absolutely very interesting. And by the way, following up on that, we didn't show the data, but if you look at other downstream markers, the next step, as you and I both mentioned, was inflammation. And if you look at the inflammatory markers, they're pretty regularly down also. The NFL and the synaptic and markers of neuronal distress, sometimes they're down, sometimes not. That finding isn't as robust as the p-tau, the total tau, and the inflammatory markers going down with both of the drugs, at least for all the data that I've seen with them. Yeah, really good question and really biologically very interesting.
Yeah.
Again, I think 10 years from now, we might be giving anti-tau along with anti-amyloid.
Yeah.
Oh, is it possible to listen again? Brian will have to tell us. Do you see any brainstem effect? Really good question, but as you know, amyloid in the brainstem is, Dr. Small mentioned the Brock and Brock stages. Very late in the disease, you might see amyloid in the cerebellum or brainstem. But at the MCI stage, we pretty much don't see it. So I have yet to see a case of RAE or H in the brainstem related to the therapies there. Mm-hmm. And because there's no side effect, there's no symptom from the brainstem then. Mm-hmm. Yeah, really good question.
Here's I see another issue. There's been pushback on the use of these therapies. People have argued that, well, the effect size of these treatments comparable to the symptomatic drugs we've had around for decades, methazole, rivastigmine, and so forth, and yet the side effects and costs are higher.
Mhm.
I think there's something to be said for that. On the other hand, I thought it was quite interesting when you looked at that post hoc analysis and some of the milder cases, or there's a subset of patients who seem to have a more robust response. And, if we could pinpoint that, I think that would be a real advance in the field.
No, I agree 100%. And along those lines, as we mentioned, both of us, that we're now doing pre-symptomatic trials. And the biologic reasoning is that maybe when someone comes in with MCI and they've got 20 years of pathology developing and a lot of downstream things already set in motion, maybe it's too late to head it off 100% just by targeting amyloid. On the other hand, if we catch them during the 10 to 20 years before they get symptoms, maybe we'll get lucky and have a bigger effect size than we see once they have symptoms. Yeah, really good point there. And by the way, 60% of people in one trial and 50% in the other were on donepezil, memantine, whatever the prescribing physician wanted. So the effect size here is added to the effect size of those. So I still put people on both of those because they do have a small but beneficial effect. And then I add these in there along with that. Yeah, absolutely. Oh, anti-epileptic. Yeah, it's a little tricky. In the old days, of course, it was Dilantin, Tegretol, and phenobarb, but you don't want to use those in someone with mild cognitive impairment, or they'll look more likely like they have Alzheimer's. I use Keppra a lot. The reason is it's easy to use. Now, a few percent of people do have side effects, but majority are okay. Something like Lamictal has a very low side effect profile, but it takes so long to get them on it. By the time you get them on it, the ARIA is gone, and so are the seizures. So I give them Keppra today, and it works. And then after 2 months, I start tapering it. And a certain number of people with Alzheimer's will have seizures anyway because of the Alzheimer's. In that case, and I've got the luxury of time, I'll use Lamictal because I never see side effects. And I don't know, Dr. Small, if that's your feeling also about it, but the problem is if you go up too fast or down too fast with Lamictal, then the Stevens-Johnson syndrome is a potential issue. But if you've got the luxury of time, you can go up slowly. It's a very safe drug with very few side effects. Oh, negative amyloid PET. Yeah, that is absolutely fascinating. And I'm sure Dr. Small has the same thing. I see, I've probably got 100 amyloid PETs in the last 6 months since lecanemab and amyloid PETs are being paid for by insurance. Of the 100, 80 have been positive, 20 have been negative. To me, they look the same people, right? So it shows you that even someone who only sees dementia just can't tell who's got a lot of plaques and who doesn't. So if they don't have plaques, though, well, there's no point in putting them on the medication, and the insurance won't approve it. So those 20 people I did not put on. On the other hand, I do know from experience that once in a while I've gotten an amyloid PET that was negative, and 4 years later I've gotten one that was positive. So I don't tell these people, I'm never going to see you again, you're fine. I tell them, I'm going to follow you, we'll give you Aricept and Namenda, and if something changes, we may see if insurance will allow us to get another amyloid PET, just in case you're one of the ones that has a late positive, because I would hate to miss the opportunity to treat them if it became positive later on. But there are people that go through the whole thing and they're never positive. And I don't know if none of us, I think, knows, is it a different disease? Is it Alzheimer's with, we define Alzheimer's as having amyloid, but maybe someday we'll define it as some people having amyloid, but some people having other biologic markers. And maybe it's the same disease, who knows?
Well, actually, I would amend that as we define it as having amyloid and tau. We go back to
good point.
Yeah. And let me just one practical question, and I guess our time is up. We'll close. Are they reimbursing for MRI scans, the serial MRIs?
Yeah, I for all of them, I have not had a single problem,
Okay.
and even the extra ones. And part of it, and I don't ever like to not say something truthful, but the truth is, a lot of times the added MRIs I'm getting because of a symptom. So I just write down rule out stroke because that's what I'm doing.
Right.
ruling out stroke. Then I never have a problem getting it paid for. But even the routine ones, I don't have to write that. I just say it's ruling out ARIA. I have not
Right.
had anybody argue about that on the MRIs.
Well, I really enjoyed your presentation and with some great questions and points brought up here. And I want to thank everybody for participating today.